I think a place to start is about misconceptions, and when we think about palliative care, there are two major misconceptions that I think we make, and I think it will become clearer as I talk. The first one is we always think about the person who's dying, and it's as if just that dying part of it is a thing that is the dying person is the main focus. But that's not how we live. We live in the context of the people around us. There's a new document out called the Lancet Commission on the Value of Death, and I highly recommend it. It's written by my friend and colleague Libby Salno and a number of other people. And it's really about giving the context in which death occurs. And it doesn't just occur for the person with the illness, it's something experienced by everyone. The other thing that I think is worth bearing in mind is what Alan Kelly here calls the 95% rule. 95% of the life that's lived by the person with the illness is not with any contact with professional service. And the astounding thing about palliative care is that if you look in the literature about what living well means in the context of end of life, both for the person with the illness and the caring network, the literature isn't sparse about what living well means. It's absent. It's unbelievable. And what this means is that we have made the terrible assumption that if we pay attention to the symptom management of physical, social, psychological, and spiritual distress, that we will give people quality of life. And this is absolutely not the case, as we will see. I love this book, The Body Keeps the Score. I hope you've all read it, and if not, it's well worth having a read because there's so much for us to learn from it. It's primarily a book about trauma, but it's about being human, and this quote is particularly meaningful. Social support is not the same as merely being in the presence of others. The critical issue is reciprocity. Being truly heard and seen by the people around us, feeling that we are held in someone's mind and heart. For our physiology to calm down, heal and grow, we need a visceral feeling of safety. No doctor can write a prescription for friendship and love. These are complex and hard-earned capacities. And I would add to this, it is not just about knowing that we are held in the hearts and minds of the people around us. It's that we hold them in our own heart and mind. There are three huge blind spots in palliative care. First one is equity of access. So only 25% of the people who die have a diagnosis of cancer, and not all of those have access, either direct or indirect, to specialist palliative care. And what that means is that 90% of palliative care services will see people with a diagnosis of cancer. That what happens to the people who suffer sudden death, murder, suicide, accidents, whatever, is that when you think about when you reframe what's going on to not just the person with the illness, but everyone involved, which is all of us, you can see that in terms of access, palliative care is a minority specialty. And that doesn't mention inequity of access in terms of race, in terms of gender, in terms of homelessness, in terms of prison population, in terms of sexuality. Actually, we absolutely have to do better. If we're going to talk about end of life care, we need to make end of life care available to everyone. So what matters most, I've just told you about, and I'm not going to talk about bereavement, but my God, we are missing something massive with grief and loss. I wanted to, there's barely a talk goes by where I don't show this slide. It's a slide of reduction in odds ratio of mortality across several conditions. And what you can see is that social relationships are more effective at helping us stay alive in a short 7.5 year period of the study than giving up smoking, drinking, diet, exercise, and massively more effective than the drug treatment of hypertension. Why is this the case? It's because social relationships are a biological evolutionary phenomenon. They are, when you look for them, you find them everywhere in human beings. And you don't just find them in human beings, you find them across the animal kingdom. What you're talking about is hundreds of millions of years of evolution. And human beings, we have done so well because we are profoundly social creatures. Humanoids have been walking upright for the last 2 million years across the planet, and Homo sapiens for the last 200,000 years. Evolution has included social relationships. And it's worth having a look at a TED talk by Robert Waldinger about the Harvard and Glueck studies of adult development that have been going on since 1938. And it's like a 12-minute talk or something like that. It's a brilliant talk. And of course, the conclusion is, if you want to live a long, healthy, happy life, it's all about social relationships. And in fact, you can think about survival of the kindest being a much more appropriate term, rather than what is the British imperialist term of survival of the fittest, invented by Herbert Spencer, which is not, was the beginning of social Darwinism, which absolutely had racist overtones. And survival of the kindest is perhaps a much more appropriate description of how we have survived by love, care, and cooperation. There's now a field of human social genomics, started by Professor Steve Cole. I run a podcast called Survival of the Kindest, and he's on it, and he gives a brilliant talk about how social relationships are built into every part of us, including genomic expression. And when we think about in the context of ill health, whether it's terminal or not, we have increasing fatigue, decreasing mobility, decreased social contact, loss of a sense of purpose, of meaning and value in life, with a loss of sense of well-being. And if we keep in our mind that we are not just talking about the person with the illness, but the caring network, we can see that this sense of loss of meaning and purpose and loss of well-being can affect a wide variety of people who are involved in the experiences of death, dying, loss, and caregiving. And actually, when you start thinking about these social networks, if you start to describe them, what you can see is you have the person with the illness. The inner network consists of perhaps somewhere between 5 and 15 people. The outer network can be anything from 5 to 200 people. And that's without the resilient communities that support people undergoing experiences of death and loss in their own community. And when you start looking at the available social resource in the context of somebody dying, living and dying in a community, the resource is enormous. And it is the social relationships that are of primary importance. The 95% rule applies. Health professionals like to think that they are central to the person with the illness. But when you look at these network maps and ask the person with the illness where the health professional lies, they actually lie at the level of either community or service delivery. Health professionals are essential, but not central. And you can think about kinship, and kinship in particular in the broader definition, not limited to family members, but kinship in the context of Indigenous communities covers both people and place. It covers the ground on which we walk, the air we breathe, and the water we drink, and the plants that we eat, etc., etc. And this is called the social ecology of care. And when you think about it like this, what you can see is that you have an incredibly rich resource of love and friendship, of the most valuable things that we have in our life, which is available to people from light social contact to close family members. And that this area in the context of palliative care is largely unexplored. What does help mean? Again, if you're coming from a health professional background, when you ask health professionals about what help means, they talk about hands-on care. But actually, there's so much more than that. When I run these workshops, which I call network enhancement, which is about how do you mobilize these networks of support. And somebody came up with this fantastic phrase, which described it so well. The biggest thing that helps is the love, laughter, and friendship. And when you look at the practical tasks, the shopping, the cooking, the cleaning, the lifts, the looking after pets, doing the gardening, that those things all help, but they have extra meaning when they are given with love, laughter, and friendship. And it might be from a complete stranger, it might be from someone we know only a little, and it might be from our closest friend. But you can see that this is about living. This is about relationships. This is about what makes life meaningful. And it's not that the professional help isn't important. It's just that it's not the major bit. There's a fantastic document called Yarning About Sad News and Sorry Business that was prepared by Palliative Care Queensland. And they were looking at, they had kitchen conversations with Aboriginal and Torres Strait Islander communities. And the content of this document actually talks not just about their own community, but every community. A failure to appreciate diversity and acknowledge complexities within communities condemns policies and programs to failure. There's a fantastic talk by Ernesto Ciroli about his life as an entrepreneur. And he talks about, again, it's another TED talk, he talks about when he was a young man taking farming to the Zambezi Valley. And they grew these fantastic tomatoes and these incredible zucchini until one night the hippos came along and ate the lot. And when they went to the farmers, they said, "You never told us about the hippos." And the farmers said, "You never asked." And that's what happens time and time again with professional care. Each community is different. And if you don't understand the community, you don't understand about what is appropriate. And furthermore, that communities don't just exist in neighborhoods. From the public health palliative care perspective, whole population includes communities of workplaces, of educational institutions, of prisons, of places of worship, of museums and gallery and the media, of state sector. Communities are everywhere. And when we're thinking about a whole population approach, which is inclusive of relationships, we're thinking about action in all of these areas. In particular, Alan Kelly and I wrote an article called Palliative Care: The New Essentials, and we wanted to somehow capture all of this. And that we know very well what specialist and generalist palliative care is, and the professional world that inhabits. But as we were saying, this is more about harm reduction and less about health and well-being. The health and well-being is the stuff that happens in our homes and in the civic parts of our lives, in our workplaces, in our institutions, etc., etc. And the key to all of this is how we can work together. That, if you like, the chain that binds this together is community development, which is crossing all the sectors. I'm not going to talk about that. Very briefly, you can think about how you renegotiate the professional space to make sure that professionals start in community and work back, thinking about what do communities best do themselves, what do communities and services best do together, and what do services best do. And if you think like that, and that you sequence it through community, you can then start seeing how professional services can participate in community development, in public health palliative care, in community engagement, community development, prevention, harm reduction, early intervention. And likewise, generalist palliative care can do the same. And it is the responsibility of the specialist teams, not just to participate in the community aspect and the civic aspect, but actively make themselves available for the generalists so that the generalists have the support when they need it. When you're thinking about communities, what can communities do? Well, building up resilient networks of support, with the main emphasis being love, laughter, and friendship, is the key bit. But there are things that you can do to improve death literacy, to skill up caring networks, to increase the neighborhood capacity to care for those people undergoing the experiences of death, dying, loss, and caregiving. The Compassionate City Charter is a 13-point public health perspective on how you cross each of those sectors to make sure that if you are caring for somebody who's dying and you're in your workplace or your trade union or in your educational institution, that not only are there policies in place which are appropriate to support you, that the institution that you are talking about is compassionate and caring. You can see the Compassionate City Charter on the website of Compassionate Communities UK. So why would you use a compassionate communities approach in clinical practice? Because it massively expands your horizon of the different things that you can do to help people in the way that is most meaningful to them. And this narrows down into the one-to-one clinical consultations. These are clinical skills which have a public health palliative care perspective. I'm just going to very briefly mention that if you apply these same principles, not just to end of life care, but to whole populations like we did in Frome, what you see is extraordinary examples of improvement in a variety of healthcare outcomes. In our particular example, this was prior to the pandemic, emergency admissions in Somerset, whole population emergency admissions went down by 15%, whilst in the rest of Somerset, they went up by 30%. And that's on the background of there are no interventions ever which have reduced whole population emergency admissions. You can look at other great examples of where people are taking this approach. This is much more than just social prescribing. Social prescribing is probably only about 10% of the total picture about the things that you need to do. You can find great examples. Obviously, there's Bromley by Bow, there's Nuka Health System in Alaska, and other examples around the world. So when we're thinking about end-of-life care, we want to have big aims. We want it to be available for everyone, irrespective of age and diagnosis. We want it to transform communities wherever they are. And we want to get rid of this artificial separation of chronic illness with death and bereavement. And we want to get rid of the obsession that palliative care has around place of death, because people are more interested in how to live well. Now, I'm going to just finish with the introduction to the Oxford textbook of Public Health Palliative Care that Alan Kelleher and I have edited, which comes out on April the 30th, that gives a extensive look at all of these different areas of public health palliative care, and hopefully you'll be able to hear the video. Hello and welcome to the introduction to the Oxford textbook of Public Health Palliative Care. My name's Dr. Julian Abel. I am one of the editors, along with my colleague and friend, Alan.
Hi, I'm Alan Kelleher, friend and colleague of Julian Abel. I'm the co-editor with Julian on the Oxford textbook of Public Health Palliative Care. And together, we're going to introduce the book as a whole. And the first thing I should say about public health palliative care is often people think of public health in the way that universities teach and research public health, and that is in terms of the surveillance sciences. People often talk about public health in terms of epidemiology or health services research or the bench sciences, or they think historically about public health, such as sewerage, clean water, infectious disease, sexually transmissible diseases, those kinds of things. But in this particular case, and in our book, and within the field of palliative care, when we speak about public health palliative care, we're talking about the health promotion traditions, the traditions that emphasize the practice models, such as community development or social ecology or health policy or services redesign or public education, health and end-of-life literacy. They're the kinds of things that we emphasize. And conceptually, health promotion is also about a balance between health and well-being and illness and disease. And traditionally, palliative care has tended to emphasize the illness and disease side. And that's why the emphasis has been firmly and wholly largely on symptom management or symptom science. And of course, health promoting palliative care or public health palliative care does have an emphasis on that as well. We're interested in the prevention and harm reduction and early intervention around the experiences of illness and disease. and some of the social morbidities, such as loneliness or job loss or school refusal, and stigma and social rejection. So we're interested in that too, but we're also interested in health and well-being, which is the more counterintuitive aspect of palliative care. People often forget that there are positive things that are associated with living with a life-limiting illness, or living with caregiving, or living with grief and bereavement. There's not just fear, but there's courage. There's not just loneliness, but there is love and growing intimacy. There is reminiscence and there is meaning making. And there's a whole group of positive things that are associated with the social nature, not just of dying, but of caregiving and grief and loss. And so the promotion of those health and well-being aspects and experiences at the end of life go together to help with the prevention and harm reduction of the social comorbidities associated with those experiences. This book is about the promotion of those things together, the promotion of health and well-being, the development of the practice models that would help us do that, and the practice models that would help us with prevention, harm reduction and early intervention in this new approach, the public health palliative care approach.
And we also wanted to emphasize that death, dying, loss and caregiving is not restricted by disease or age. And likewise, not by gender, by diversity. It is a question of social justice, that we need to find a population-based model that will help everyone. And also that it's not just about the person who has got the illness, it's also about the caring network of people who are affected by that. And that caring network extends into community, it extends into our places of work, our places of worship, our educational institutions, it extends everywhere. Death, dying, loss and caregiving is not just a professional issue, it's a social issue that involves all of us. We invited international experts in the field who've done an incredible job in writing different chapters, and the book is organized into 6 sections. The first one is the case for public health palliative care, which looks at the social nature of dying and the essential components of it. We then have a section on basic concepts and theories, then basic practice methods, then population-based approaches, and finally, evidence-based and education and training. I think that's enough from me. I've spoken enough. Hopefully it wasn't too controversial, and I suspect that as a lot of you will be familiar with many of these ideas, but